All right. I'm seeing folks starting to filter in. Hello, everyone, and welcome to the Co-APCD Research Showcase. I'm going to give it just a couple more seconds here, and then we can get going. Okay. We're on a kind of a tight schedule today, so I want to be sure to go ahead and get started. Um, so hello, welcome to today's Colorado All-Payer Claims Database Co-APCD Research Showcase. My name is Sarah. I am a digital communications specialist here at Civic, and I'm going to just go ahead and get us going. Thank you all for being here today to talk about the cool work being done with the Co-APCD. So, whoops. Jumping ahead, here we go. All right, quick look at our agenda. Real quick, but it's a pretty tight agenda today, like I mentioned, so I want to get going quickly. We will give you first a quick overview of Civic and the Co-APCD, and then we're going to turn it over to Lauren and Emery to take us through the new dental health dashboard from Civic. Then Jack is going to talk to us about his research into healthcare in rural Colorado and opportunities that they've identified for expansion. Then Greg is going to take us through claims identified opportunities for healthcare cost savings. And finally, Andrew's going to wrap us up talking about his research into the Colorado option and impact on behavioral health utilization and costs. So just a real quick rundown, some housekeeping materials here. All lines are muted. If you have a question that comes up during someone's presentation, we will have time for a very brief Q&A after each presentation. Please go ahead and just write your question into the chat box, and then we will take a look at those after each presentation. If we are not able to get to your question, I will be posting the presenters' emails into the chat at the end of their presentations. Please feel free to go ahead and take that email and shoot them your question, and they will be happy to follow up with you. This webinar is being recorded, and a link to that recording, should you like to revisit it, will be posted on our website on the event resources page at civic.org. Real quick, who we are here at Civic. We are an independent nonprofit. Our mission is to equip partners and communities in Colorado and across the nation with the resources, services, and unbiased data needed to improve health and healthcare. The way we do that is through working with our change agents. Our change agents are people who are working to identify ways to lower costs, improve care and health here in Colorado. We work with a wide variety of people throughout the healthcare landscape, everyone from government and legislators to health plans, hospitals, employers, and as we're going to focus on, especially today, researchers. And the way that we serve them and work towards that mission is primarily through our work as the administrator of the Colorado All-Payer Claims Database. We, through the Colorado All-Payer Claims Database, release both public co-APC data that is available on our website through interactive dashboards and downloadable data sets that explore healthcare utilization, cost, quality, equity, and more in Colorado. We also do licensed non-public releases of data for those who have questions or are working on a project that is aiming to improve health or healthcare in their communities or in our state. We also offer analytics services, research and evaluation services, and do a lot of community engagement work. Real quick look at what's in the Co-APCD. We now have over 1.3 billion claims going back to 2013 all the way up through, it says 2024, it's actually 2025. We do 2025 claims data. That accounts for 33 commercial payers and includes Medicaid and Medicare, both FFS and Advantage. So, all told, that represents over 70% of insured lives here in Colorado and accounts for over 5.7 million lives in the state. What we don't have in the co-APCD, we don't collect federal program data. So, VA, TRICARE, Indian Health Services. Obviously, we are not able to collect claims from uninsured individuals. And finally, because it's optional for ERISA-based self-insured employers to submit data to the co-APCD, we do collect some data from some ERISA-based self-insured employers, but not all. And with that, let's get into the presentation and get it over to who you're really here to see. So I'm going to go ahead and turn it on over to Emery and Lauren, who are going to talk to us about the dental health dashboard.
Thank you so much, Sarah. My name is Lauren Harvey. I am the Director of Government Relations for the Colorado Dental Association, and I will be happy to do this presentation with Emery, who will talk through a lot of the actual data. But we're very excited to talk through this, a commercial dental health analysis that we partnered with Civic on this year, and we are thrilled with the information that we now have publicly available. You can go to the next slide. So the purpose of this project that we undertook, so obviously it goes without saying that oral health is a vital part of overall health and well-being. It's something that we talk about all the time. If you have poor oral health, chances are you also will have other issues with your overall health that are going to impact you on your day-to-day life. So it's really important to understand how we can increase access to dental care and especially preventative dental care. So we partnered with Civic to introduce an interactive dashboard, which will provide a clear picture of dental care in Colorado. So we asked them to look at commercial claims across Colorado for these 3 years and have them now publicly available in this dashboard. We're really thrilled with this because we do believe this promotes a greater public understanding of utilization, trends, and it's also, whether you're a consumer, a dental provider, other provider, a policymaker, or an advocate, this data can really help drive conversations, best practices, and also policy changes that may be needed to increase access to care. And this kind of data really hasn't been available in the past. We've sometimes relied on self-reported data from providers or trying to get information from insurers. So this is really a great tool that we now have publicly available. And on the next slide. So just wanted to share some reasons why we are hopeful this will be really impactful for Coloradans and some use case examples. As you can see here, there may be an opportunity to identify if there are disparities. So if we see, lower utilization in rural parts of the state for certain codes, that may tell us that we should be doing some investigation and research into what may be happening and if there's a need to identify barrier access and barriers to care. We also are hopeful that this can help us inform our public programs. We know that having some benchmark data for our Medicaid program is especially helpful. Medicaid often benchmarks to Medicare, which is not available for dental, so this is even more important in this area of medicine, of dental, to have an opportunity to identify what actual costs and actual payments are so that we can incentivize the public program to be sufficient and adequate and allow more Medicaid patients to receive dental care as well through having more providers involved. And we just really are interested in having that greater transparency into dental payer rates and utilization so that we can have greater transparency around the value of dental plans and really bring transparency to any health equity considerations reflected in current reimbursement models and looking at, subsequent reforms that can help improve health outcomes for sometimes overlooked populations.
Hey everyone, my name's Emery and I am a healthcare data analyst here at Civic. And I am excited to share our new dashboard with all of you. But before we hop on to that, just want to briefly touch on our methodology here. This analysis includes commercial dental claims data from the Colorado All Payers Claims database for calendar years 2022, 23, and 24. It explores trends in utilization and cost using our current dental terminology codes. And it also provides breakdowns for various cost measures listed here. I went ahead and I dropped the link in the chat for those of you who would like to follow along. I encourage you to navigate there as I also try to gracefully share my screen. Alrighty, we should be able to see my screen now. Before we drop in, I just want to share that when navigating to dashboards through the Civic website, you can do so by going to this Get Data button. We can then navigate to public data and featured focus areas in order to explore all of the dashboards that Civic has available, including the dental health analysis, which we will be exploring today. Within the website, there's a ton of other really useful information about our dashboards, including our specific methodology and summary of findings, which I encourage you to dig into after this presentation. Scrolling down, we will then find our awesome new dashboard, which hosts 3 different pages. First, we're going to dive into our cost tab. We have 2 specific views on this tab, which we're able to filter using our filter bar above. Here we have our years, which include 2022, 23, and 24, geography options such as statewide, rural, and urban, and then our specific cost measures, including the allowed amount, charged amount, health plan only, and patient only. If you are curious about the definitions for those, you can hover over our information button and it'll provide you more details on that. Orienting ourselves with the dashboard itself, there are 2 primary views on this page. The first view includes CDT codes with the average payments and then percentile payments, where the 25th percentile payment represents payments that 25% are below this value. Again, if you want more information on these definitions, you can hover over the information button and it'll provide you with information for that. One of my favorite parts about this table is that it's interactive. And so if we select a CDT code on this table, it'll then populate the visual below. And so now we're able to see the variation in allowed amount by commercial payer. So we can see the minimum, median, and maximum payment by commercial payer. But my favorite part is that if we have a CDT code that we know, or a group of CDT codes, we can type it into the bar here. So for example, say we wanted to look into imaging services. We can type that in here and it'll filter to all of the imaging CDT codes available, and we're able to easily compare the costs. Making it even better, we can sort by the highest to lowest, easily making it so that we can compare the values. Moving along, the demographics tab, of course, is public health professionals. We know is a great place to go to better understand disparities that exist. Before looking into this dashboard, I just want to highlight there are 2 different sets of filters we want to be aware of for this page. The first set has the year and geography, like we already navigated through on the first tab. It also has the demographics options, which include age group, race, ethnicity, and sex, as well as our measure groups. For cost measures, we include the total cost as well as cost per person per year as well. And then for utilization, we include total utilization, which represents the total number of services, as well as utilization per 1,000 people. Now, not forgetting that second filter, you can either compare cost measures to the utilization, or it probably makes sense to have it more concise and select another utilization measure to compare. In order to easily compare our demographic groups above to the trends, by hovering over, it'll bring a specific demographic group of interest into view. Finally, we have our top CDT code chart. We get a lot of questions about this chart. So again, I really want to encourage you to use this information button for additional information. It has great definitions of what exists here, as well as friendly examples of how to interpret the data, because we all need that sometimes. So for example, here we see for 0 to 17-year-olds, periodic oral evaluations make up 20% of billed services. Finally, last but not least, we have our Trends tab. This tab is going to automatically populate with all years of our data and all different geography options. So with that, I just want to highlight that the text bands at the top here are all going to represent statewide values with all years included. However, if we want to look at a specific data year, we can select one of our analysis years, so 2022 through 24, or we can select a specific geography of interest, and it will filter to those specific values. Finally, we have all of our different utilization and cost measures here as options for filters. The last thing I want to touch about this dashboard is that we have the option to download any of these images so you can throw it into a presentation or send it quickly to a legislator. Love to see it. Again, I know this is a really quick run through of the dashboard, so if you have any questions, you're always welcome to send them my way, or if you have questions now, you can drop them in the chat. Thanks, guys.
Awesome. Thank you so much, Emery. I'm going to go ahead and take back the screen here. We'll open it up. Looks like you've got a question from Lucia in the chat while I go ahead and deal with this.
Yeah, thank you, Lucia. It says, how can the information available in the dental health dashboard impact access to care? I would just note, I think having the data in general will help us identify first and foremost where there may be, lower utilization levels. And that might tell us, is there a reason that there's less utilization of a certain code in rural areas versus urban? And I think that opens the door to us doing some further digging and guides us in investigations of where we may need to look. Are there, certain providers aren't available in that area, and how can we increase access to those provider types in dental? So I think that's, one way where it really can, just having the information available lets us identify where there may be a need and begin to explore why there is a need and what the barriers may be in a certain population or part of, the community of Colorado.
Awesome. Just give it a couple seconds more here if there's any further questions. I'm putting Lauren and Emery's emails in the chat, so please feel free to follow up with them and ask any questions that may come to mind later. Not seeing any further, I think we can go ahead and move along here. So we'll turn it over to Jack.
Hi, this is Jack Westfall. Really happy to be here, honored to be here and presenting these data. You can go to the next slide. Or do I have control of this?
It's me.
Okay, so this is a presentation that I'm doing for another organization, the North American Primary Care Research Group. This data was selected as a distinguished paper. I put this together, then I traveled for 3 weeks, just got back yesterday and didn't have time to adjust it. So you get to see the whole thing, but I'm not going to go through the whole thing. It's going to be a little quicker. What we're trying to look at is using an exemplar zip code to look at the healthcare services obtained by people within a geographic location compared to the care that they receive in other parts of the state to see if we can maximize local care delivery. We used 80759 because that's my hometown. It's the place where I work clinically at the Yuma Hospital and Clinic in Yuma, Colorado. Very excited to be able to share these data with you. Next. Next, you can go past the land acknowledgement, and the map of rural Colorado and critical access hospitals. You can go to the next one. So this is what we're trying to look at. So all the healthcare services delivered in 80759 is that middle circle. So these are services that are specifically located within this zip code. But then people who live in that zip code may access services in other parts of the state. That's the big circle. So that tells you all the services necessary in a given year for people living in a geographic area. And then the little circle is healthcare services delivered within 80759 to people who aren't residents of 80759. They come in from a neighboring community or a neighboring county where they're visiting. This really will help us identify the care that a community needs and help a hospital or a healthcare system identify what of those services they can most likely deliver locally versus what needs to be done elsewhere. Next. This is the context. You can go to the next one. So we wanted to describe the breadth and volume of healthcare services, and we sought to answer the three following questions. What services were accessed by patients living in one community? Where are those services obtained? And who provides clinical services to those patients? Number three, we're not quite there yet. We're still cleaning the data to identify the level of provider who's delivering the services, but we did get sort of the what and the where. Next. So this is Yuma. This is the zip code 80759 out on Highway 34 and Highway 59. For those of you who don't know where it is, next. That's a little picture of Yuma and the grain elevators. Next. We used the all payer claims data for 5 years using ICD-10, CPT, E&M codes, and the same zip code by patient and delivery site. Residents of Colorado zip code, there's about 4,600 people that live in that zip code. And then again, the services delivered there and the services obtained elsewhere. Next. Oh, a couple more pictures of Yuma. Next. Okay, so there were about 5,294 residents of 80759 received care over a 5-year period. There is some movement in and out with a stable population of about 4,600. There are about 600 more people that come in and out during the time period. 3,300 of those people received some care, at least a little bit of care in 80759, but 1,900 received no care in 80759, but got some care outside of 80759. So there is a large population who never get medical care within their own zip code. Now, one caveat to this is the radiology that we do at the Yuma Hospital is read by a Nighthawk service elsewhere. And so while the radiology is done in that zip code, it is read in another zip code. So that's where the most of the billing comes from. And so the radiology data are a little bit sketch. So next. So here's what we have. Here's a little heat plot of what kind of services they get. You can see office visits are a big chunk, radiologic exams, psychological and psychiatric services, hospitalization, and then you get down to the smaller services, nursing homes, cataract surgery. Some of these you can't even read, echocardiography, dialysis. So this is sort of the breadth of services obtained by people living in 80759. Next. Next. So each year there were about 18,000 services for patients living in zip code 80759, 6,500 office visits, 1,100 hospitalizations, 1,500 radiologic exams, 700 ER visits, et cetera, et cetera. You can see as we get smaller and smaller, about 40 deliveries done for people who are living in 80759. Next. However, you'll see in that first, you'll see in the next heat map, let's just go to that one. So here we have these broken out by where they got the services. So office visits, about half of the office visits were obtained in 80759. But as I said, radiologic exams, while we do a lot of radiologic exams in 80759, they're read elsewhere. And so the billing data comes from a different zip code. Hospitalizations, you can see a number of people are hospitalized within 80759, but it's a small portion of people hospitalized. Next. ER visits. The majority of people who go to the ER who live in 80759 get that ER care locally. That's what we would expect. They live there. They're in an emergency. Where are they going to get care? They get it locally. Next. Physical therapy. We do most of the physical therapy locally. We have very good PTOT department. So most of the people getting physical therapy get it there locally. Next. Dialysis. Guess what? Yuma 80759 does not have a dialysis unit. So we don't do any dialysis. None of the dialysis done for people living in 80759 is done locally, nor are the deliveries. The next smaller circle down there in the lower right. We don't do any deliveries locally. So you can see there's a broad array of variation in the services that are delivered locally versus services that are done elsewhere. Next. Oh, we talked about this. Next. So this got us thinking, well, what are the services that we're not ever going to do? And what are the services that we already do a little of that we might be able to capture more of the market share? So we're never going to do open heart surgery, right? Yuma's not going to do that. I'm not going to do that. So that's probably not a place to expand services. But in the medicine specialties, that purple, the purple piece of pie with the dark blue in the middle, medicine specialties, the vast majority of medicine specialty visits are done outside the zip code, but some are done locally. Why not try to make that dark blue piece of pie a little bit bigger? Same with orthopedics, the purple piece of pie, the dark purple. We do some orthopedics. We do hips and knees and shoulder. We do a lot of surgery, but we could potentially capture more of that. We already have the facilities set up for that. Same with general surgery. We have facilities to do general surgery, but we're not capturing a big piece of that market. So this is going to help our hospital administrator and our hospital team think about what are the services that none of these are done at the Yuma Hospital, and what do we already have? What would we have to build from scratch? What do we just need to grow? Next. This just says what I just said. You can go on. And then I have a series of slides, and I think I'm about out of time, so I won't go through these too much. This is, again, all the care provided within 80759. This is all the stuff we do. You won't find obstetrics and deliveries on here. This is care delivered in 80759. And then we were wondering about our market in the surrounding communities. So how much of the care that's provided in 80759 is for the surrounding community? So next slide. This is all other zip codes. So the dark is people within our zip code, but we provide a substantial amount of care to people who live in other zip codes. Our catchment area is much bigger than 80759. Next. Here's the next town over, Otis, where I was born, 80743. You can see we provide a substantial amount of care there. What this figure does not show is what proportion of care to people who live in Otis is delivered in 80759. And that will be our next piece to say, for the people who live in 80743, how much of their care is delivered in 80759? Could we capture more of that? It's 13 miles away. Could we capture more of that? Next. Here's Akron, another small town in eastern Colorado. These are the top 5 catchment areas for zip codes. Next. Ray is a small town 27 miles to the east, but they have a very large healthcare system. They have a surgeon and an orthopedist and a very stable primary care service. So we don't get a lot of care from 80758, a little bit, but not too much. Next. So here's the sort of crux of that. Are there ways to expand healthcare services within 80759 in areas that we're already delivering those services? And how might we capture more of the people who live in those surrounding zip codes into our facility so they don't have to travel to the Denver, the Front Range area? Specifically thinking about primary care, specialty care, orthopedic surgery, general surgery. This has led us, these analyses have led us to hire a new ophthalmologist to do cataracts because we weren't capturing any cataracts. But we're now able to do cataract surgery in Yuma, and that's helping us deliver those services locally. Next. I think that's it. Next. And next. Thank you very much. And I'm happy to take questions, or I'm happy to have my email in the chat, and I would love to talk with anybody. Our goal is to do this as a pilot in 80759, a place where, because I live there, I have lived there, I work there, we can test the fidelity and the veracity of these numbers. Is this really what's going on? Because I work there. And then we're hoping to be able to do this in dozens of other zip codes to help healthcare facilities identify places for growth and places for expansion. Thank you.
Fantastic. Thank you so much, Jack, for that awesome presentation. I will go ahead and just give it a couple of seconds here. If anybody has any questions or anything that's springing to mind, I will also put his email here in the chat in just a second, so you can follow up with him if you wake up in the middle of the night with any thoughts or questions or anything like that. It's really interesting, so thank you so much for sharing that.
First off, if you wake up in the middle of the night, I'm so sorry. I don't want to be that guy.
Sometimes I wake up in the middle of the night just thinking about questions about healthcare.
The all payer, I have to say thank you to the APCD for making these data available. This has been a lot of work, a lot of fun, but is meaningful, impactful for rural communities. And I do wake up in the middle of the night thinking about these analyses. So
Yeah.
thanks.
So very interesting. And I can see everyone in the chat agreeing. Seeing no questions at this time, I think we will go ahead and press on. But if you have a question that does come up, please drop it in the chat, and Jack can answer. Or where are we going? Or we can follow up. How did we go back here? I don't know. Okay.
I'm so sorry I had some extra slides in there. I
No problem.
apologize. They were my
No,
extras.
that's all user error. My apologies. Sometimes I don't know. It's like you get on a presentation, you forget how computer works. All right, we'll go ahead and bring it over to Greg now with no further ado. So go ahead, Greg, and take it away.
Hi, thank you, Sarah. My name's Greg Smith. I'm with Health Price Partners, which is a Colorado nonprofit. We were formed with the idea of, is there a way to improve the functions of markets in healthcare? With the idea or the hope that that would reduce cost, and the further hope that if cost is reduced, that improves access. So we're trying to benefit the state in that way. My background is consumer products. Other members of our team are former healthcare executives in both the for-profit and nonprofit provider area. So that's what we are and what we're trying to do. Next slide, please. Okay, before we really get started, let's look at the landscape of markets in healthcare and do a little bit of orientation. The Affordable Care Act of 2010 had a provision in it that required healthcare prices, the government could require healthcare prices to be disclosed. And in 2019, regulations came out requiring those disclosures. And there have been several sets of regulations since, continuing up through this year. So this is an active area where the government is increasingly requiring disclosure. The idea here behind these disclosures is that more data will facilitate markets and that will help consumers. But as the young woman on the left of this picture shows, there are some obstacles. The data is somewhat incomplete and the prices are not binding. And a major issue, which we'll touch on later in the presentation, is right now health insurance plans, which is how most people probably get health insurance, don't offer a benefit if you price shop. And so the question on the table is, can we take this landscape and try to improve things so that consumers can compare prices and save money? Next slide. What we're going to do in our presentation here is we're going to talk a little bit about free markets in healthcare in general terms, try to reference some data in doing that, and then we'll talk about ways to fix the system. But we think it's important to talk for a minute about markets in healthcare because many people in the United States feel that we do have a market-based system. And we think the answer to that is, in some ways, we sort of do, but in significant other ways, not really. And why is that? Let's dig there a little bit. The major issues in getting a free market to operate in healthcare is there are a couple factors that are they're baked into the healthcare system that insulate it somewhat, not completely, but somewhat from market dynamics. Big one is demand. You know, when something breaks, it has to be fixed. You don't have an option, you know, oh, gee, I need this very expensive procedure. You can't delay it. That's also that that you don't control demand works both ways on the supply and demand equation, because if demand is static, it's what the economists call inflexible, or inelastic rather. It's inelastic to price. You don't see hospitals running, you know, a special on heart surgery or hip replacement because that is just not the nature of the demand. So that means there's no price reduction to encourage demand, but there's also not really a penalty for price increases because the demand is fixed. And that's a dynamic that has to be addressed if you want to get a market running. Major one is the presence of intermediaries. Again, this is endemic to our system. It is a feature of the system. We have diagnosing intermediaries, physicians, who determine what you need. And then we have financial intermediaries, also called insurance companies, which tend to insulate patients from some costs, hopefully the major costs, by charging them a premium for that insurance. But that takes the patient a step away from the transaction in terms of ability to control cost and also motivation to control cost. Insurance companies do want to get costs down, but they're not as motivated as an individual patient might be. Next slide, please. A quick recap of how markets actually work at a consumer level. This slide shows the actual ways that markets try to influence price. On the left side of this little chart is a list of major expenses for a household. We're looking throughout this presentation, we're looking at healthcare from the perspective of a consumer. And these are the major costs: housing, transportation, and healthcare is kind of in the middle at 14%. Across the top of the chart are the major strategies that are used by consumers to control cost. And you can look at those and you can see them in your daily life. You can compare prices. You can negotiate prices. You can sometimes substitute things, and so on and so forth. Most of those categories of spending that a consumer encounters are susceptible to one or more of those strategies, not healthcare. The big strategy, and arguably the only strategy in many cases for a consumer to control healthcare costs, is by decreasing quantity. In other words, you forego care. And the data on this is extensive and very solid that yes, in fact, many consumers of healthcare do forego care, and they're subject for another presentation, but we are lacking in healthcare really good tools for consumers to control their prices. So that's what we're trying to address here. Next slide. We've looked at a lot of data as part of our analysis, and because of our time limitations, we didn't want to make this a data-heavy presentation. But here is some data that I think is interesting. What you're looking at here is one procedure that we think is representative, cesarean section birth. It has some features, in some cases, the timing of that can be controlled. The facility of that can be controlled by the consumer, not in all cases. There are many other procedures that are expensive. Knee replacement is another, many, many others. What the dots each represent what Cigna, which we just picked them as an insurer, what they would pay for this procedure at various hospitals in Colorado. Each dot represents basically a hospital. At the bottom of this chart, there's dollars. On the left side, the leftmost dot is about $3,500. There is a hospital in Colorado that will do this procedure, and they quote it officially, we will do this, or for Cigna, at $3,500. On the far right side of the chart, the lowest dot out there is $27,000. That's, and everything else falls in between. The point of this chart is to show same insurance, same procedure, but look at the variation. This variation means, among other things, there's something driving variation in these prices, and we think to a large extent that it's a lack of market dynamics. There are other forces that are driving these prices. And as I say, this is a separate subject, and I'm not trying to beat up on Cigna or anybody here or hospitals for paying different rates. The point is, this is the landscape we're facing. There's great price variability. And one of the reasons it's variable, we're pretty sure, is that markets are constrained in operating in healthcare. Next slide. Flipping through my notes here. Okay, now we get to the part of the presentation where we talk about, okay, what do we do about this? We've talked about markets, how they work, in some areas, but in a lot of significant ways, they don't work well. We really dug in with Civic's help in terms of Colorado spending. And we found a couple of things that to us were very interesting. The average out-of-pocket spend for a person who's incurring healthcare costs, some people have no spending in a year. They're young, healthy, usually both or often both. But when they do spend, it's $1,400 per person on average. And we looked at that and said, aha, this is worth digging more, because for most families, this is a significant expense. So there's something to be worked with here in terms of trying to save money. Looking at very broad data sets. And if you look at that data and you say, well, what if you could somehow shop these prices? For Colorado, we sampled to a 25 to 40% savings if you could possibly shop. This is consistent with many other studies academically that show savings up to 40%. So we feel at this point we verified this is worth looking at. And before we get into sort of where we think the savings might come from, a little bit of data to talk about, because we try to let data guide our choices and where we do our investigation. There is good, solid consumer research out there where consumers say, yeah, if I could shop, I would. If it got my costs down, I would do that. And it's 89%. And in, retail dynamics, that's significant. That gets your attention. The consumers would like to shop for care, but the obstacles that we talked of earlier in the presentation, the data is incomplete. It's somewhat complex. It can be confusing, is preventing consumers. And then just kind of an aside, we think Colorado is a really good place to maybe try something for all the reasons listed. We have Civic, We have healthcare policy and financing. They have some excellent price comparison data on their website. And the state is very healthy. Next slide. Okay, so here we come to what do we do? Our best, and we're working on this. We do not have this equation solved, but we think there's probably an app that needs to be built. Recent advances in artificial intelligence may make it less expensive to build a powerful app than it was as recently as a few years ago. Our best guess, mainly in outpatient, is that if you could robustly price shop procedures in Colorado, you might be able to save consumers $100 million per year. But there are two really big challenges. To do this, the tool has got to be easy. And this is where a little bit of my background comes into play with consumer behaviors. There's a limit to how much time people have and how much learning curve they're willing to invest. And probably as big or bigger is we have to do something that we call within Health Price Partners a way to break the financial insurance intermediary barrier. We call it the intermediary barrier. What is that? Right now, going to, using my earlier example, if I have Cigna for my insurance and I work really hard and find a lower price for a Cigna procedure at a hospital, there is no incentive for me to do that. I don't get a break on my insurance. I don't get a price benefit to myself. And so we have to really look hard at that. And that's where our focus is right now. So I'm done. If anyone has any questions, I'll be happy to try to answer them.
That was so great. Thank you so much. We do have one question in the chat from Kat, who asks, how does price transparency help consumers when we are at the mercy of our providers' participation in certain network hospitals?
The answer at the moment is it does not help you, and for exactly that reason. And again, we're not beating up on any part of the industry here, but there's a structure in healthcare that makes it, there's no reason that you should shop for price if you have insurance generally. And we have got to find a way to pierce that system, or we're not going to be able to save money for people. At the moment, you're absolutely right.
Yeah. And not seeing any other questions immediately. And I do want to keep us moving along, but that was a great presentation, Greg. Thank you so much.
Thank you.
I will put his email in the chat as well here in just a second. Feel free to follow up if you have any other questions that come to mind. So I will go ahead and kick it over to Andrew, who's going to go ahead and take us home here.
All right, thank you so much. You can move to the next slide, please. My name is Andrew Shermeyer. I'm a PhD candidate at the University of Minnesota, and I'm going to discuss the effect of eliminating cost sharing on behavioral health service utilization and affordability in Colorado. Next slide, please. All this research, I owe a lot to a lot of people. So thanks to Civic, these individuals, and some funding. Next, please. Great. So to set the context, one of the challenges we face is providing comprehensive but also affordable behavioral health care. There's a lot of barriers when it comes to this, including stigma surrounding behavioral health, availability of services, and more financial ones like insurance coverage and the high cost of care. So there have been numerous strategies states have undertaken to address this. Of late, there's been one has been to eliminate cost sharing altogether. We've seen this in New Mexico. And another example is in Colorado, actually, in the Colorado option. So if anybody is unfamiliar with the Colorado option, in 2023, Colorado passed House Bill 21, implemented, I should say, House Bill 21, 1232, established this public option, quasi-public option, if you will, and required all insurers in the marketplace to offer additional standardized plans with shared benefit designs. Part of this benefit design was a $0 behavioral health office visits. So essentially, economic reasoning, we would think that, oh, no cost sharing, this could encourage and incentivize use. And that was exactly what the policy intended. However, it remains unclear if consumers actually responded to the $0 copays. And this leads to the next slide, please, of the research objectives. First, to determine if individuals enrolled in one of these Colorado option plans utilize more behavioral health services than those enrolled in a non-option plan. And also, another objective is to actually quantify the difference of out-of-pocket cost savings for these two groups of people. Next slide, please. To accomplish this, I conducted a retrospective cohort study using the Colorado APCD, using years 2021 to 23. So 2021 and 2022, purely to establish baseline health status. I used all 3 years to find people who were continuously enrolled or had 11 or more months of coverage each of those years. This removed people from the special enrollment period, which has been in the literature shown to have some potential adverse selection, so that was important. And then the outcomes I'll discuss later are from 2023 only. But so the sample included about 50,000 individuals in total between 18 and 64 who were continuously enrolled in a marketplace plan or coverage, I should say, between these years. The treatment group was about 7,200 individuals enrolled in the Colorado option plan. I considered the comparison group the remaining 43,000 individuals enrolled in a non-option plan. So if you're getting alarms in your head, it's totally valid. There is treatment selection bias via defining treatment this way. I'm going to discuss how I mitigated that in the methods slides. So next slide, please. So my outcomes of interest, I cared about the probability of using any behavioral health services. This is a binary yes or no outcome. I also cared about the amount of behavioral health services used for individuals that used any to begin with. This is kind of like intensity of usage is another way of thinking of this. And then lastly, of course, to quantify the out-of-pocket savings, we want to know the average cost of behavioral health visits. So next slide, please. That'll go into the methods. So I used a two-part model for this. It's also called a hurdle model in the literature. So the first part of the model is an equation called a decision model. And this identifies the probability of using any behavioral health services based on someone's treatment status or the plan they were enrolled in 2023. From this, we go into our outcome models, the second part. And so the second part is concerned with only, is conditional on people passing the hurdle or having used services to begin with. And I ran separate equations to model usage and cost to get those intensity of utilization and the cost outcomes. But I want to specify, because of the treatment selection bias, I had to use inverse probability of treatment weighting, IPTW, to mitigate this effect. I'll save you all from the methods discussion about how that's actually done. I'd love to talk about it later. It's really cool, but moving forward, let's talk about some results in the remaining time we have. So interestingly enough, in terms of the decision model, that binary outcome, I didn't find a difference between the probability of using any behavioral health services based on whether an individual was enrolled in a Colorado option plan or a non-option plan. Below, I'm showing the average marginal effect of treatment compared to people enrolled in that plan or in one of those plans versus a normal non-option plan. And the 95% confidence interval is also listed there. So you're seeing it cross zero. So it's statistically insignificant. Next slide, please. The outcome model for utilization, I actually didn't see any association between the plan choice of an individual and the amount of services utilized. So there was no difference I found between enrolling in an option and a non-option plan between the counts you used. Again, we have average marginal effects. The confidence interval crosses zero, not significant. Next one, please. This is the kind of interesting result. So as expected, we're seeing some savings from enrolling in the Colorado option plan. And it makes sense. Eliminating cost sharing should, reduce out-of-pocket spending. But now we've quantified it, and it's about $23 less. So what does this mean? And next slide, please. So I think this just raises some questions, right? And I have why didn't utilization increase? So I have a few reasons. One is that costs couldn't be the only barrier. In the 2023 Colorado Health Access Survey, it was the first time that the survey said that cost wasn't the main barrier. And also the benefit design doesn't really touch upon stigma, availability, or accessibility of services. The second reason, I think we need to consider the context of behavioral health services. A lot of the time they can be correlated with crises, and you don't really plan on a crisis by definition. So therefore, I think people might be less price sensitive to these services than other services. The third reason is competing mechanisms. There could be prior authorizations, different networks, even provider reluctance to see individuals based on negotiated reimbursement rates. We've seen this in Medicaid. The literature points to that. I've not investigated that yet. I'll talk about next steps. But the other reason would be a lack of awareness of health benefits. The 2024 Consumer Engagement in Healthcare Survey said that about 40% of individuals don't know their behavioral health benefits in insurance plans. So this could just be something we've seen, it's a new product when people selected one of these plans. Next slide, please. I'll just wrap it up quickly. Essentially, eliminating cost sharing reduced out-of-pocket costs like we expected by an average of $23 a visit, but we didn't see that increased utilization of behavioral health services. And I think this suggests that we really should prioritize, that we need to think about the non-price barriers to behavioral health care, such as the availability and the accessibility of these services. And I plan to do more work on this to investigate how provider networks and reimbursement rates changed. And I'd also like to see if there's variations based on region or if there's heterogeneous effects in case, the newly enrolled in 2023 had a different effect than those continuously enrolled. So yeah, that wraps it up. So thanks so much for listening. Feel free to type any questions or email me with any, and I'm happy to discuss this.
Awesome. Thank you so much, Andrew. That was great. Looks like we've got just a couple of very quick questions here. Oh my goodness, there's a whole bunch, and we're about to go over. So everybody, I would ask, I'm so sorry, if you can reach out to Andrew. His email is right here, and I'll put it in the chat as well, and ask him your questions. I just saw like 4 come in, so I don't want to hold everybody over. I'm sure people are anxious to get to lunch or on to their next meetings or whatever, and I want to be able to get us out of here. So, my sincerest apologies for that, Andrew and everybody whose questions we weren't able to get to. But I am copying the chat as well, and I will follow up with that as well from my end. So, my apologies. Thank you so much, Andrew. That was really, really interesting. Clearly, everybody else thinks so too. All right. So thank you all so much for coming to our presentation today. We will get a follow-up email that will have a recording as well as further information in the slide deck. So feel free to touch back with our presenters as other questions or thoughts come up. Feel free to reach out to us if you sparked some ideas for how you may be able to partner with Civic, use co-APCD for any of the projects you're working on. Please connect with us. We are on Facebook, LinkedIn, and not Twitter. Got to get that out of there. We are on Instagram, though. And sign up for our newsletter. So with that, I will let you all get on to your afternoons. Thank you so much for your time today, and have a great rest of your Thursday. Thank you.